Good afternoon. This is your lecture for Poisonings, Overdoses, and Intoxications. I'm going to use the Jeffrey Guy slides, and the majority of the information is going to come from the Jeffrey Guy text. I do want you to reread the Mosby sections that were listed on your Blackboard course shell because those medications are going to be complementary to what we're going to be talking about today. To cover your learning objectives, we are going to talk about the use of activated charcoal in poisoning, options available for Tylenol overdose, for cyclic antidepressant overdose, and how patients will present. And we're going to talk about medicines used in the treatment of cyclic antidepressant overdose, like sodium bicarbonate, mag sulfate, levofed, diazepam, and dilantin. We're going to talk about medications used in beta blocker overdose like atropine and glucagon. And we're going to talk about Haldol. We're going to talk about medications used in the treatment of cocaine intoxication. And we're going to talk about Narcan use. We're also going to talk about organophosphate poisoning just a little bit and the use of atropine and 2-PAM. We're not going to go into great deal with toxicology. We're just going to talk about the medications involved in poisonings, overdoses, and intoxications. So to begin with, the objective of any emergency provider caring for a poisoning victim is pretty simple and straightforward. Your initial priority is going to be the same as any emergency. You're going to need to maintain a patent airway. You're going to need to make sure you can adequately ventilate your patient, and you need to make sure that there is sufficient perfusion of blood to your critical organs. After you make sure you've got those three things, A, B, and C, the next thing you need to do is either reduce the toxin or prevent absorption of the toxin. So those are your priorities. Now, a lot of you are too young to remember the use of Ipecac. And Ipecac is designed to cause you to vomit because the thinking was, we've ingested a toxin, we need to get it out quickly, so we're going to cause them to vomit. Because everybody knows absorption does not occur in the stomach, it occurs in the intestines. And so if we keep the medicine from going into the intestines, then we can help the patient. The problem is, you can cause your patient to aspirate, which blocks their airway. It messes up your ABC sequence. You can also cause further damage if they've ingested a caustic substance. In other words, a substance that burns going in or has a pH that's less than 7. It's caustic. It burns. If it burns going down, it's going to burn coming back out. So we don't want to do that. So Ipecac induces vomiting in about 90% of people 10 to 20 minutes after it's taken. After people take Ipecac, it can be pretty stressful vomiting. It's pretty violent. So that's no longer a pre-hospital recommendation. Like I said, Ipecac is contraindicated for anything that burns going down because it'll burn coming back out too. And the American Academy of Pediatrics now recommends that Ipecac no longer be used at all for pediatric patients. So sometimes you may still find Ipecac in the medicine cabinet of people, and maybe they have tried to administer something that would induce vomiting. If they know that there's been an ingestion. The most important thing we can do as pre-hospital providers is make sure that everybody knows the number to poison control. And that number is 1-800-222-1222. I'll repeat that again, 1-800-222-1222. The first pharmacologic intervention in poisoning case is the administration of activated charcoal. Activated charcoal will reduce absorption of ingested poison by providing a large surface area to which the poison can bind. 1 gram of activated charcoal can provide about 2,000 meters square of surface area to which a toxin can bind, which limits its ability to be absorbed by the body. So that's a lot. 1 gram can provide up to 2,000 meters square of surface area for poison to bind to. Activated charcoal causes patients to have nausea and vomiting. More frequent, smaller doses of activated charcoal can decrease the frequency of vomiting associated with charcoal administration. So before administration, evaluate your patient's level of consciousness and their ability to understand what you need to have them do. Because if they have an altered level of consciousness, automatically you should be concerned with an airway problem, especially because large doses of activated charcoal can cause nausea and vomiting. You're not going to want to give activated charcoal for all ingestions. Some ingested substances are not absorbed by activated charcoal. Things like iron, lithium, alcohol, ethylene glycol, organophosphates, and some acids and bases, and cyanide. Those things are not absorbed by activated charcoal. Now, Tylenol overdose is probably, your book says it's one of the most common intentional overdoses. And for me personally, it's probably one of the most painful overdoses to bear witness to. Patients who overdose on Tylenol take days to die. And not even to a point, not even hemodialysis will work to clear out the Tylenol overdose. In children, the typical presentation of a Tylenol overdose is abdominal pain, nausea, and vomiting. These things are often absent in adults, even after large amounts of Tylenol have been taken. Clinical symptoms, like an overdose, can be absent for days before a deterioration of liver function, and that's because when the Tylenol breaks down, it stores itself in the fat tissue in the body. So it keeps being released over a period of time. All you can do in the pre-hospital world with a Tylenol overdose is be supportive, provide supportive care, maintain your ABCs. Initially, your care is going to be the same as any other critical patient. You need to make sure you have a patent airway, monitor your breathing rate, regularity, and quality. You need to make sure you have adequate perfusion and adequate circulation. Your patient's probably going to have an altered mental status, so keep that in mind. Go ahead and establish an IV and start running, some fluid, normal saline. If you have a problem like low blood pressure, then treat it with a bolus of fluid. If they're having seizures, treat the seizure. Whatever the problem is, treat the problem. And here's a little side note you need to know. When treating overdoses, avoid dextrose solutions, because if the patient has a seizure, administration of Dilantin will result in precipitation of that drug. So in other words, when you administer Dilantin into a fluid containing glucose, the glucose and Dilantin will mix and cause crystals to form. So that's important for you to understand. Do not administer a dextrose-containing fluid to your patient when you suspect they have a history of seizures or may be having seizures, because when you mix Dilantin in that fluid, it's going to form crystals. Once the crystals form, that also forms in the vein itself, and then you've just caused a thrombus to form in your patient. So overdose from an antidepressant is a pretty common cause of overdose death. clinical manifestations of cyclic antidepressant overdose include a depressed level of consciousness, wide complex tachycardia, hypotension, and even seizures. After you make sure you've maintained ABCs, the first step is to give activated charcoal if there's no contraindication. So a decreased level of consciousness contraindicates administration of activated charcoal, and that is because they can't protect their airway, and large doses of activated charcoal can cause nausea and vomiting. Cardiac arrhythmias are the most life-threatening manifestation of cyclic antidepressant overdose. A widened QRS complex or ventricular tachycardia is probably the most common thing you're going to see. If your patient has a wide complex tachycardia, then treatment with sodium bicarb may be appropriate depending on what your medical director will allow you to do. Some patients develop cardiac torsades de poids, and that would be treated with mag sulfate. Of course, this summer we're going to talk about cardiac rhythms, so you'll have opportunity to put these treatments in practice. A lot of times your patients who've overdosed on cyclic antidepressants will have low blood pressure, and it may not respond to a fluid bolus, and so you're probably going to need to give them norepi or neosynephrine. And by the way, I want to say norepi is a peripheral vasoconstrictor. Remember, we talked before about epinephrine and norepinephrine and how naturally these chemicals are secreted from your adrenal gland and your kidneys. So epinephrine is beta specific. It likes to work on the heart. It increases contractility of the heart. Norepi is a peripheral vasoconstrictor, which means it constricts the blood vessels in the extremities, and that's how it can help manage blood pressure. Seizures are also pretty common in cyclic antidepressant overdose. Seizure activity can go from, brief seizures to grand mal seizures. And a lot of times, the longer the seizure activity goes on, the more likely the patient is to develop an abnormal heart rhythm like ventricular tachycardia. So, you need to treat your seizures probably with Valium or another benzo. Diazepam is usually effective, and Dilantin can also be used, but you need to consider the use of Dilantin, especially in the treatment of cyclic antidepressant overdose. So you probably want to follow your local protocols for that. I don't know a lot of people who carry Dilantin on their ambulance, but I'm sure that there are some in Kentucky who are carrying that actively now. So patients who have overdosed on beta blockers usually have bradycardia. They may have a heart block, and they're probably going to have low blood pressure. Some beta blockers can also cause people to be delirious, to have seizures, or to go into a deep coma when they're taken in excessive doses. A lot of times these symptoms will show up within 6 hours of ingestion. And your treatment for bradycardia, first thing you're going to do is give them some atropine, 0.5 to 1 milligrams, and give them a fluid bolus, 20 milliliters per kilogram. In most of the cases, beta blocker overdose, atropine is not going to work, just one dose of atropine. And administration of atropine after the overdose of beta blockers is only symptomatic therapy. If atropine increases the heart rate, the effect of the atropine is often short-lived, and then your bradycardia will come back. The main goal of your therapy is to improve perfusion. The main goal of therapy is to improve perfusion. So atropine is the initial treatment for bradycardia from beta blockers, but glucagon is considered the antidote for beta blocker overdose. Okay? Glucagon is the antidote for beta blocker overdose. Glucagon's success is not always predictable in some patients, though. Some people it'll work right off the bat, but then there are other people who literally have no response to glucagon. So it works by increasing the heart rate and blood pressure. That's how glucagon works. It increases the concentration of a chemical known as CAMP, cyclic adenosine monophosphate. Cyclic adenosine monophosphate. An increase of CAMP will result in increased heartbeat and a faster heart rate. So that's how glucagon works. It works on the heart to cause increased contractility and increase heart rate. So sometimes your doctor may request that you put your patient on a glucagon drip. And this is something you'll have to just work with and become familiar with. It's not always a pre-hospital intervention, but if you are transporting a patient with a cyclic antidepressant overdose and you're transporting them to another facility, they may be on a glucagon drip. So you'll need to understand how that's going to work. So another thing I want to point out right here, drugs commonly used to treat bradycardia and low blood pressure would be epi, norepi, dopamine, and those are not successful in the treatment of beta blocker overdose. So just because a beta blocker overdose causes your patient to have bradycardia doesn't mean that bradycardic treatments are going to help your overdose patient. That's why you need to know about things like glucagon and glucagon drips. Okay, so let me back up here just a second. I want to talk to you a little bit about amphetamines and methamphetamines. Amphetamines and methamphetamines will increase the fight or flight, and your patient will present a lot of times the same way as they would if they have circulating epi and norepi, right? So they'll have tachycardia, maybe hypertension, maybe their temperature is going to be a little elevated, they'll be agitated, you'll have pupil dilation, and that's because there are supernormal levels of catecholamines present. Patients with an amphetamine and methamphetamine overdose can also have an MI, can have cardiac arrhythmia, can have seizures, stroke, or intracranial hemorrhage, or even death. And I think I may have jumped ahead a slide there for you. Okay. So when we manage amphetamine and methamphetamine intoxication, we need to think about benzodiazepines. Activated charcoal is never used in an amphetamine overdose because most of the drug is absorbed by the time EMS arrives at the hospital. What we want to consider is benzodiazepines, and those would be diazepam, midazolam, and lorazepam. These can be used to control agitation. Sometimes you can use haloperidol, also known as Haldol, if your patient doesn't respond to benzos, but I want you to keep in mind that Haldol has a side effect of psychosis. So you really have to weigh that out, and not every patient responds with psychosis, but it is a side effect. The way benzos work, The way benzos work is that they bind at the benzo receptor site, and they bind with GABA. And when either a benzo or a GABA binds to that receptor site, it allows additional chloride ions to enter the cell, and that causes the cell to be less excitable. So that's how benzodiazepines work for amphetamine and methamphetamine intoxication. When you administer a benzo, it competes with the same receptor site as GABA, and it causes the body to release additional chlorine ions, which causes the cell to be less excitable. In other words, the cell is now not interested in carrying out orders or passing messages because it's happy with the benzodiazepine. So cocaine intoxication results in an adrenergic response, which means adrenaline, right? So adrenergic is adrenaline. So your patient is going to have tachycardia, high blood pressure, dilated pupils, hyperthermia, and maybe agitation. Initially, you're going to want to treat your patient with Valium or Versed, which is benzos, maybe some Ativan. Your second line administration is going to be Haldol. But remember the psychosis some patients experience with Haldol. Cocaine can produce a lot of problems, serious problems with the heart, beyond just tachycardia and high blood pressure. It can lead on up to myocardial infarct. So chest pain associated with cocaine is ischemic chest pain. Patient initially should be given benzos such as diazepam, and up to the point of treatment for cocaine intoxication is similar to therapy for amphetamine use. So you keep that in mind. Like I said, cocaine can produce serious cardiac complications. Beyond just tachycardia and high blood pressure and chest pain, it can lead on up into myocardial infarct if the ischemia has gone on for long enough. So how do we treat this patient? Well, because chest pain with cocaine is often ischemic, we need to use nitroglycerin. Okay, so we're going to treat chest pain like chest pain. So we can consider giving aspirin. Aspirin reduces the effectiveness of platelets to form clots. But we're also going to want to give nitroglycerin, right? So spasms in the coronary arteries and occlusion with platelet plugs result in heart muscle not receiving a critical amount of oxygen, and that's what's causing the ischemia. So we need to stop that problem. So if chest pain continues, even after we've given aspirin and we've given benzos and we've given nitroglycerin, we need to consider morphine. Reggaeton is a good medicine to use here. If patient's chest pain keeps on going, Reggaeton can be used in specifically cocaine situations. Phentolamine is an alpha adrenergic blocker, and it's aimed at reducing systemic blood pressure and vasoconstriction of the coronary arteries. And that's important that you know that, because nitroglycerin relaxes vascular smooth muscles and it dilates peripheral arteries and veins. Reggaeton, phentolamine, does what? It dilates coronary arteries, okay, which takes the pressure off of the heart. Adrenergic receptors, when stimulated, produce a clinical response of hypertension, tachycardia, dilated pupils, agitation, and hyperthermia. Your alpha receptors result in vasoconstriction and hypertension. When you give your patient Reggaeton, then that drug will bind to the alpha receptors, and it prevents the cocaine from producing vasoconstriction and high blood pressure. So that's important to know. Hypertension from cocaine should not be treated with beta blockers because it can exacerbate the problem. It can cause coronary artery vasoconstriction to be worse, and it can cause an increased chance of death. So one thing I want to point out here, heroin is more soluble in fat, and so it allows the drug to reach a higher level in the system more rapidly than other forms of opiates, and that's typically why it's more often abused. I just want to point that out to you. So heroin is more soluble in fat. You can also use it more ways than one. A lot of times people will inject heroin, but that's not the most common method of use. The most common method of use is snorting. Some places it's smoked, and it's more soluble in fat. Heroin is going to cause your patient to have a depressed level of consciousness because it's an opiate. So you're going to need to be worried about airway, breathing, and circulation. The classic presentation, confusion, ataxia, now the most common management of narcotic overdose is called a coma cocktail, and you all know I'm not a big fan of cookbook paramedicine, and coma cocktail comes straight from cookbook paramedicine. I want to say right up front, you better have a very strong gut feeling that something is wrong with your patient along these lines if you're just going to administer dextrose and thiamine just for no reason. Narcan will not have an adverse effect to someone who is not suffering from an opioid overdose. So you can administer Narcan if you suspect opioid overdose with virtually no side effect. But dextrose and thiamine are different altogether. Thiamine is used for patients who have Wernicke-Korsakoff syndrome. A lot of times it's because of chronic alcoholism. What happens when your patient's a chronic alcoholic is their body can't break down nutrients the same way that they should before. So you administer thiamine, which is vitamin B1. You administer thiamine to help treat that problem. If your patient has low blood sugar, obviously you should check the blood sugar first if you suspect that they're unresponsive, because it could be diabetes related. Check their blood sugar level before you administer dextrose. If you suspect your patient's an alcoholic, maybe you can administer some thiamine. And Narcan is for opioid overdoses. Now the way that works is it binds to opiate receptors, and you need to remember that it's short acting. It does not reverse the opioid, but it will kick the opioid out of the receptor site for long enough to try to help the patient. So this brings us to organophosphates. And organophosphates are a class of chemicals found in insecticides and fertilizers, and they're common in agricultural environments. So organophosphates have been around for a long time, almost 100 years. So naturally, humans are going to find something negative to do with them, right? So now we've used them as sarin gas, we've used them as VX, and these class of chemicals can gain access to the body through inhalation, ingestion, and absorption. And if you'll remember, back in 1995, sarin was released in a Tokyo subway by a terrorist group. So there was that. And you need to know a single drop can kill an adult. And the name of the group, and you'll have to forgive me because I'm terrible at pronouncing these words, but it's Aum Shinrikyo. Aum Shinrikyo is the name of the group that released the sarin gas in Japan in 1995. They had roughly 1.3 liters of sarin in its liquid form, and we know liquid takes up less room than gas. And remember, a single drop can kill an adult. They had 1.3 liters of this stuff in 1995. Organophosphates poison the body by inhibiting the enzyme acetylcholinesterase. Now, acetylcholinesterase breaks down acetylcholine. Without acetylcholinesterase, you're going to have a buildup of acetylcholine, and it's going to cause overstimulation of the parasympathetic nervous system. So what that means is, if you have overstimulation of your parasympathetic nervous system, that's overstimulation of your feed or breed nervous system, okay? So we're going to have diarrhea, urination, meiosis, which is contraction of the pupils, bradycardia, bronchospasms, emesis, lacrimation, and salivation. It's also known as dumbbells. So if you have a buildup, or if you have an overstimulation of your parasympathetic nervous system, you're going to have dumbbells. So how do we manage it? Well, if your patient's been poisoned by organophosphates, that's going to start showing up within about 5 minutes of exposure. Okay, so they're going to have bronchospasms, they're going to have fluid buildup, copious amounts of secretions in their respiratory system. So we're going to need to make sure we have a patent airway. Initially, your drug intervention is going to be atropine. The most dangerous manifestation of organophosphate is going to occur in the respiratory system, like I told you, with the buildup of secretions and the bronchospasms. So we need to make sure we have a patent airway. If you intubate your patient, then you don't need to use a nectine, and I don't know how many of you use drug-assisted intubations on your ambulance, but the reason why you don't use a nectine is because of the way it breaks down. The body cannot break down a nectine if it's been poisoned by organophosphates, and what that means is basically your patient has a prolonged, where they're paralyzed, prolonged paralysis. So the thing I want you to remember, atropine reverses the effects of muscarinic receptors, but the nicotinic effects will persist and your patient will continue to have profound muscle weakness. So when your patient has organophosphate poisoning, you're also going to need to administer 2-PAM. And 2-PAM is listed on page 230 of your Jeffrey Guy textbook. It's a cholinergic agonist, okay? And the way it works is it causes a reversal of the feed or breed by potentiating the fight or flight. Now, if you have any questions about this lecture, or if you're unsure of any of the medications, you can just send me an email. Like I said, we're going to cover toxicology during the 3rd semester of your EMS course, but I want you to be familiar with these medications. And some of the most important things I want you to remember. want you to remember that treatment of cocaine-induced hypertension can constrict coronary arteries, and it can produce cardiac complications, including death. I also want you to remember that you don't use activated charcoal with an amphetamine overdose, because most of the drug is already going to be absorbed by the time you get to the patient. Amphetamines absorb pretty quickly. I want you to know that the dose of glucagon used to treat beta blockers is significantly higher than the dose that you would use to treat hypoglycemia. I want you to know that when you give glucagon, most of your patients are going to have nausea and vomiting, so you need to make sure to have your suction ready. I need you to know that atropine is used for bradycardia treatment, and that the dosage is 0.04 milligrams per kilogram. But if you're using atropine to treat a patient who has been exposed to organophosphates, then you're going to use a much higher dose of atropine on that patient, and you can repeat it as often as needed until their secretions dry up. I also need you to know that in cases of beta blocker overdose, epi and norepi and dopamine are not going to help you. And remember, don't use dextrose-containing fluids when you're treating somebody who's had an overdose and they're having a seizure, because if you give them a dextrose fluid in their IV and then you are going to administer Dilantin to stop the seizure, then that'll cause crystals to form, and you don't want that, because now you've caused your patient to have crystals in their veins. So be sure and spend some time on this section and really understand these treatments, when to give them and why to give them, and which things not to mix. And I'll see you all on Monday.